Hello and welcome everyone. My name is Matt Shepard. I'll be moderating today's session, Medicare 101, Where to Begin and How to Make the Most of Medicare, presented in partnership with I AM ALS. Our presenters today are Center for Medicare Advocacy founder and senior advisor Judy Stein and associate director Kathy Holt. And we are also very pleased to be joined today by Aditi Minkoff, Vice President of Community Support for I AM ALS, for introductory remarks, and her colleague Patrick Nicholas, ALS Support Lead, who will join us for Q&A and discussion. You'll hear a little bit more about I AM ALS in just a moment, but if we can move to the About the Center slide. The Center for Medicare Advocacy, for those who don't know, is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities by providing exceptional legal analysis, education, and advocacy. Now I have a little more housekeeping before we begin in earnest. We have quite the crowd today. Amazing registration, loved the turnout. And we have folks from 48 states and DC and Puerto Rico. So really, really excellent that you could all join us. But because we have such a massive crowd for the bulk of the presentation, we're going to keep folks on mute. And we do plan to take live questions at the end of the prepared presentations. In addition to the live question option, though, we also want to note that we have a questions section in the little control panel that you should see on your screen. You just have to hit the small white triangle to open it up, and you can type questions in there. In addition to that, we have the more traditional chat section of the control panel as well. I'll be monitoring live questions and anything entered into the questions section, and my cohort, Jeff, will keep an eye on the chat for us. In addition to those, we also received literally hundreds of questions and comments during the registration process. And I know that our presenters today will try to address common themes from those as well. Finally, everyone should have received a copy of the slides for today's presentation at the email address that you used to register. And if not, those are available in the handouts section of the control panel that you should see. Finally, there's a couple little controls on the side of that panel. There's a little orange arrow that'll let you hide the panel so it's not in your way. There's a little square that'll let you put this whole thing into full screen view. And there's a little picture of a hand. If you click on that hand, it will electronically raise your hand so we know you have something to ask or say during the live discussion portion. I think that covers everything from me. So I want to thank everyone again for attending and for your great feedback during registration. And I will now bring up Aditi Minkoff, Vice President of Community Support for I AM ALS, to get us started. Aditi. There we go.
Hi, everyone, and thank you so much, Matt, and everybody at the Center for Medicare Advocacy. We are so grateful for this partnership and for all of the incredible work that you all do. And for myself, my name is Aditi Narayan Minkoff, and I, as Matt mentioned, am the Vice President of Community Support at I AM ALS. Matt, can we move to the next slide, please? And a little bit more about I AM ALS. We are a patient-centric nonprofit that has set out to revolutionize the path to ending ALS. Next slide. If you aren't familiar with ALS, it is a progressive neurodegenerative disease that kills motor neurons, which means that people who are diagnosed lose the ability to move, speak, eat, and breathe. On average, people live between 2 to 4 years after diagnosis, and it is currently 100% fatal. Next slide. So what does I AM ALS do? We provide critical support and resources to people who are impacted by ALS. We create a safe space for community members to organize around their priorities, and we activate this incredible group of community members to feel empowered to become strong and vocal advocates in this movement, which is really their movement. We do all of this with the goals of a faster patient-centered research system, improved clinical outcomes, and increased quality of life for people affected by ALS. Next slide. So the how behind the what, we have hundreds of incredible volunteers who have self-organized into 10 affinity-based community teams, ranging from legislative affairs and clinical trials to community outreach and veterans affairs. The teams work to raise awareness and educate about ALS and ensure that the patient and caregiver voice is always heard and listened to. I mentioned earlier that ALS is 100% fatal. To change this, we advocate for federal funding for ALS research and for people to have access to experimental therapies and a whole lot more. And lastly, we also, to support people living with ALS and their caregivers and families today, we offer a suite of support services to help people navigate the healthcare and support services systems to help them build a community of care and support. With that, I would love to also introduce my colleague who is joining me today, Patrick Nicholas.
Hi, everyone. So excited to be here. My name is Patrick Nicholas. I'm the ALS support lead at I AM ALS. I'm a licensed social worker based in the Hudson Valley of New York, and I'm really excited to be here today and look forward to answering some questions and highlighting some of our services in a bit more detail later on in the presentation.
Thanks so much, Patrick. And with that, I'm going to turn it over to Judy.
Good afternoon. Lovely to see our colleagues at I AM ALS and to know that we have such wonderful number of registrants with us today. I'm going to start the presentation on behalf of the Center for Medicare Advocacy. We're going to, as you see in our agenda, talk about how we can help, and we hope help Medicare help people living with ALS and other debilitating conditions obtain necessary care. And we're going to focus on some of the areas that we think are most important to this community, and also many of which came to us from questions that were asked by registrants for today's webinar. So we'll provide a Medicare overview, talk about the premiums and cost sharing for Medicare, assistance to pay for those costs, how to move into Medicare and transition from other coverages, and then summarize how to choose between traditional Medicare and Medicare Advantage, or at least knowing clearly what the distinctions are and what may matter to you or the person you're trying to help. So for a Medicare overview, I will start by providing a summary of the Medicare program. Medicare is a national and the original and actually only national health insurance program dedicated to people who are over 65 and people who have significant disabilities. People usually qualify based on having paid into Social Security while they worked, and Medicare, unlike Medicaid, is not based on having a low income. It's rather based on age, disability, and having been employed and paid into the Social Security system generally. It covers people also with ESRD, end-stage renal disease, and people with ALS. And folks with ALS don't have to wait the traditional 24-month period if they're under 65 and qualifying as a result of their living with disability as a result of their ALS. Generally, Medicare covers hospital, nursing home, home health, physician or doctor's visits and care, durable medical equipment, prosthetics, orthotics, hospice care, prescription medicine, some preventive services, which were expanded by Obamacare or the Affordable Care Act, and some vaccines. People can get Medicare through the traditional, or sometimes known as original program, or through private Medicare Advantage plans. And I'll be going over those distinctions later in the program. So let's talk a bit about the Medicare program in general. It is an insurance model. So what does that mean? It means that it covers some of the cost of some healthcare based on overall criteria, like would be in any health insurance plan. and certain requirements and help paying, cost sharing. The basic criteria are that the care must be reasonable and necessary for an illness or injury, and generally it has to be diagnostic for diagnosis of an injury, illness or injury, treatment, or rehabilitation. As I said, some preventive coverage is available, and that's been increased over the years, particularly as a result of the Affordable Care Act. There is cost sharing, and by that I mean co-pays, a flat dollar amount to help pay for the care, co-insurance, which is a percent of the cost of the care, deductibles, which are upfront payments before Medicare will kick in, and premiums, which are monthly payments for Medicare insurance. So let's talk about the Medicare structure. There are 4 parts to Medicare: Part A, Part B, Part C, and Part D. Part A is known in the law as hospital insurance, and it is in the traditional or original program. It's administered by the Centers for Medicare and Medicaid Services. The acronym for that, which I may use in the program, and Kathy may too later on, is CMS. Part B is known in the law as medical insurance, and that covers outpatient services generally. And then in order to meet the co-payments for Part A and Part B under traditional Medicare, folks will often have to purchase supplemental policies known as Medigap, or qualify for Medicare savings programs, or have other retirement insurance to fill in those gaps. And I will also talk about that further in a little bit. Part C is not a means of getting additional care, but rather providing the care coverage for the care that is available under Parts A and B. A, largely inpatient, B, largely outpatient, with some exceptions. So Medicare Part C is known by most all of us as the Medicare Advantage program. And Medicare Advantage is an option to purchase to get your Medicare through private insurance plans. Medicare Advantage plans exist with Part D, the prescription drug program, or without a Part D plan. So it's MA, Medicare Advantage without Part D, or MAPD, which is a Medicare Advantage plan, which also bundles in the prescription drug program. So then there is Part D, A, B, C, and D. Part D is another substantive coverage means, and that's the prescription drug program that came into effect in 2006. This too is provided by private insurance plans. If you're in traditional Medicare, you will need to purchase and choose a prescription drug plan, which is called a standalone prescription drug plan, in order to add prescription drug coverage to your Medicare coverage. If you were enrolled in a Medicare Advantage plan, very often those plans will include the prescription drug program along with the other coverages under Parts A and B. Next slide, please. So now I want to go through some of the most important coverages for the population that's registered for this webinar, and for people in general who rely on Medicare to open doors to healthcare, with a few additional pointers, particularly for people living with ALS and other longer-term chronic and neurological debilitating conditions. So here's a bit about different care settings. Inpatient hospital care to start with. Medicare Part A covers inpatient hospital care, or it's provided by your Medicare Advantage plan. This is broadly defined in the law. Essentially, it's not changed too much in terms of the details of what inpatient hospital coverage is under Medicare from when it was enacted in 1965, which says something to the order of it's essentially what people would expect to receive as an inpatient in the hospital. So that would be generally all-inclusive payment, but a capitated rate, not per service, for the care, room, and board received by the individual as an inpatient in the hospital. Part B covers outpatient hospital care. But there's a bit of confusion there that I want to point out. An individual relying on Medicare may be in the hospital, in a bed overnight, receiving medical and nursing care, but still be considered for billing purposes as a Part B outpatient patient receiving observation services. The consequences for that could be that if the individual does not have Part B, which is optional, they wouldn't have that Part B outpatient services, those Part B outpatient services covered by Medicare. Also, if it's considered outpatient services and they're in traditional Medicare or an MA plan that requires inpatient care prior to receiving nursing home coverage in a skilled nursing facility, that would not be available to them. So generally, inpatient hospital care is under Part A, outpatient under B, but observation overnight care can be considered B and has consequences. The federal government does require notice to patients if they've been placed in outpatient or observation status. Now, I do also want to talk about a particular kind of inpatient hospital care, which is more and more being referred to as inpatient rehabilitation facility, or IRF care. This care is particularly important for people who have an intense need for care and medical supervision. So that would be very important for people with living with ALS or other such conditions. And that's because the inpatient rehab facilities will provide medical care as well as intense, coordinated, multidisciplinary therapies, such as, and that's, I'll read the acronyms, PT or physical therapy, OT, occupational therapy, SLP, speech language pathology services, and PO services, prosthetic and orthotic services. One of the services, in order to be covered by Medicare, must be PT, physical therapy, or occupational therapy. And in order to be covered by Medicare, the patient receiving this must be receiving intense, coordinated, multidisciplinary care supervised by a physician who has expertise in rehabilitation and by a team that meets at least 3 days a week. Generally, it requires that the patient receive, and this is what we mean by intense care, 15 hours of rehabilitation within a 7-day period. This is important because you may hear that the person have to receive 3 hours a day of intense multidisciplinary care, but it can be spread over a 7-day period. The individual must be actively able to participate in and benefit from the therapies and must make some improvement, but the standard is not to return to the prior level of functioning before an ALS or other diagnosis or illness or injury necessarily, but to improve sufficiently to be of practical value to the individual in adapting to current impairments or disabilities, and just of practical value in his or her life. You do not need to achieve complete independence or return to a prior level of function in order to qualify for Medicare for this important care setting services. Next slide, please. Another important level of care is the skilled nursing facility level of care, sometimes known as nursing homes. Skilled nursing facility care is covered by Medicare when it's ordered and overseen by a physician or another authorized provider, which is an APRN, an advanced practice registered nurse, or a physician's assistant, a PA. In order to be covered, the patient needs to require and receive daily skilled care. Note that skilled care is considered nursing or one of these therapies that we just described. And if it's nursing or nursing and therapy together, that must be 7 days a week. But if there's no nursing and the services are just therapy, PT, physical therapy, occupational therapy, or speech language pathology services, those must be received 5 days a week. The law recognizes that they're often not available 7 days a week. The care must be always, as I said earlier, reasonable and necessary. And generally, the patient must be admitted to the nursing home, the skilled nursing facility, within 30 days of a 3-day inpatient hospital stay. Now, as I mentioned earlier, Medicare Advantage plans often waive that 3-day inpatient hospital requirement. Next slide, please. Another key level of care is home health care. In order to be covered by Medicare for care in the home, their services must be provided by and under the care of a physician, and again, or an authorized practitioner. The care must be ordered by one of those two providers, a physician or authorized practitioner, an APRN or PA, and reviewed every 60 days. And there has to be at least one face-to-face, that is, the patient sees the care provider prior to getting the services or shortly thereafter. The patient must be homebound. Now, that doesn't mean bedbound. What it means is that the patient essentially can't get the care consistently outside the home. So we're going to bring the care to the patient because the patient has an inability to leave home by him or herself and needs assistance to leave the home, and it takes a taxing effort to do so. The patient must need, again, a skilled service like with the nursing home care, skilled nursing facility care. In order to start home health coverage, the person needs to receive physical therapy or speech language pathology care services. But if those were in place, or a nurse, and if those were in place to start and then no longer are provided, occupational therapy will be a skilled service to continue home health care. Now note, a very important service for people staying at home with a good quality of life is home health aid services. Those services are only available with Medicare coverage if the patient is also receiving one of those skilled services I just enunciated. Regrettably, this care, which is personal hands-on care like bathing, dressing, providing medications, transferring someone from in bed, there are about 20 services recognized as home health aid, hands-on personal care. More and more people are having trouble getting home health aid services under the Medicare benefit, and we at the center are trying hard to press for the appropriate coverage there. For home health care in general, there is, importantly, under the law, no duration of time limitation or visit limitation. And that's unlike in the nursing home or skilled nursing facility, which is limited to 100 days of coverage. Next slide, please. Outpatient services under Part B include outpatient therapy, physical therapy, occupational therapy, and speech language pathology. And importantly, unbeknownst to some providers, there is no hard cap on the amount of the services that can be provided and covered under Medicare since 2018. So if you're told that your Medicare coverage days or services are up, that's a time to call us or look on our website, because legally that may well not be true. Another important service under Part B is durable medical equipment. In order to be covered by Medicare, such equipment must be for medical purposes. So for instance, though an air conditioner might be necessary because the person has a severe pulmonary condition, it's not considered generally medical and won't be covered as durable medical equipment. The equipment must be primarily for use in the home and must be able to withstand repeated use. That's the durable part. An important practice tip: confirm that the durable medical equipment related services that you need or are receiving or getting for someone you're helping include the delivery of that equipment, help setting it up, and training as to how to use it. Unfortunately, those things are often left behind, and then the person has equipment which is not of value to the family or the individual. Next slide, please. Prescription drugs are covered under Part D, as I said earlier. Those are provided by private plans within the Medicare Advantage program or stand alone with traditional Medicare. If you either way, you must choose an MA plan with Part D in it in order to get prescription drug coverage. Or if the MA plan you want doesn't have prescription drug, or if you're in traditional Medicare, you must choose separately and enroll in a Part D prescription drug program. Plans cover some medications, and they vary from plan to plan, and also with varying copays per each plan's drug formulary or list of covered drugs. The formularies change generally from year to year and differ from plan to plan. And I want to make some note of important good changes that come into prescription drug through the Inflation Reduction Act. In 2023, much insulin was capped at $35 per month as a copay for Medicare beneficiaries. This year, cost sharing is limited to approximately $3,500 per year. Next year, copay will be limited to $2,000 a year. And beginning in 2026, Medicare will be negotiating drug prices for a certain number of drugs and an increasing number over the years for Medicare beneficiaries. Now, I know this is an area of great interest to our audience, and we will be doing a webinar solely about prescription drugs in concert with the PAN Foundation on Tuesday, September 17th from 2 to 3 p.m. Eastern Time. You'll hear more about that from us, so stay tuned for that. Next slide, please. Now, a major practice tip that we want you all to take heart and know about is that Medicare coverage does not depend on improvement. This is long-standing truth in the law. The myth in Medicare is often that you have to improve in order to get coverage. That's not true. And this slide, which has a quote from a federal regulation, which is the law, makes it clear that restoration, the ability to improve, is not to be the deciding factor in determining whether skilled care is required. And in fact, a patient may need skilled services to prevent further deterioration or preserve current capabilities. And if that's true, and the other criteria I described for the care setting are met, Medicare coverage is available. That was confirmed by a federal court in a national class action lawsuit brought by the Center for Medicare Advocacy and our colleagues, known as Jimmo versus Sebelius. So both under federal law and regulation, and as a result of federal court ruling, there is not to be improvement required in order to receive Medicare coverage in key care settings. Next slide, please. Coverage is available to maintain or slow decline. It doesn't turn on the absence or presence of improvement, but rather on the on the presence of skilled care. The question would be, could the care be safe and effective if there was no involvement of skilled professionals such as a nurse or one of the therapists I mentioned? And if the services to provide or supervise the care require the involvement of a skilled professional to be safe and effective, then they should be coverable by Medicare if the other care setting criteria are met. That's in accord with the Jimmo case. And there's something called an important message of Jimmo and lots of other information on the Medicare agent's own website, cms.gov. Next slide, please. The Jimmo standards that I just described apply to care in the skilled nursing facility, home care, and outpatient therapy. Skilled services there, nursing and therapy, are coverable by Medicare to maintain or slow decline. To a different extent, the standards also apply to patients in inpatient rehab facilities. Those claims should never be denied because the patient cannot achieve complete independence in self-care or cannot be expected to return to the prior level of function. Next slide, please. Skilled is defined as inherently complex so that it can be safely and effectively provided only by or under the supervision of one of those skilled people. So often asked, would it be safe and effective if there was no nurse or no therapist involved at all with the provision of this care? Next slide, please. In order to determine that, the law requires that the individual's need, not people in general with this condition or any other generality, but in this particular individual's need, does this person need based solely on that person's unique condition and needs, without regard to whether their illness is or injury is acute, chronic, or terminal, or expected to last a long time. That's very important. Those things shouldn't limit care, and individualized assessment is required. And here you have the federal regulation that's I'm quoting from here. Also a practice tip to show your providers. Next slide, please. A practical tip, know your Medicare coverage criteria, as we just described generally, including that skilled maintenance coverage is available in the care settings I described. Know if your provider participates in Medicare or if you're in a Medicare Advantage plan in your particular plan. Make sure your provider is aware of some of what I just described and that he or she knows to keep documentation that will be presented with your claim for Medicare coverage. If you are in Medicare Advantage, make sure you are using a provider that is part of your MA plan's Medicare Advantage plan, or that you know and can handle the consequences of being seen by a provider outside your MA network. Next slide, please. Question to ask again is whether the professional services of skilled care is needed, nurse or therapy, for the care to be safe and effective, and is a qualified nurse therapist needed to provide or supervise that care, regardless of whether the care is needed to improve or maintain conditions. Next slide, please. As a resource, I provide this slide, which is what's on the cms.gov website as required by federal courts. It says that what I just told you is consistent with long-standing Medicare regulations and law. And it just reiterates what I've told you, that maintenance care that is skilled can be coverable just as care that is skilled to improve services. And this is a slide we hope you will keep to your present, copy, and provide to your providers or MA plan, which is equally required to abide by this law. And now I will follow this with pass the baton to Kathy Holt, our attorney and associate director, to talk about Medicare premiums and costs.
Thank you, Judy. Hi, everybody. So we're going to turn the program a little bit and talk about what you have to pay for when you are eligible for Medicare. Then we'll look at eligibility and those transitions onto Medicare and other coverage. So we'll first look at the premiums that you have to pay when you're in Medicare. Premiums are the responsibility of Social Security, meaning that's basically who the agency that deals with the money part of Medicare for the most part. Most beneficiaries, 98% of beneficiaries, don't have to pay premiums for Medicare Part A if they have a 10-year work history. And we're going to look at spousal work history. The other way to pay for Medicare is if you are a voluntary enrollee. So I know we have a lot of folks on the program today who may be entering Medicare because of a disability. So there are slightly different rules that apply if you are under 65 than if you are 65 or over. We'll touch on those very briefly, but just be aware of that. I mentioned spousal or parent work history. So if you are an individual who is a spouse of someone who worked and paid into the Social Security system, these are the rules of how you can get Medicare under someone else's record who is your spouse. So if you're currently married for at least a year, divorced and married for at least 10 years, but currently remain single. If you're widowed, married at least 9 months and single. And Social Security does recognize same-sex marriage. As far as children, if there's a child who is disabled prior to age of 22, when the parent is retired or deceased, then that child will be eligible for Medicare under their parent record. Just know that the only children under the age of 18 that qualify for Medicare are people who have end-stage renal disease. The other way to qualify for Medicare is if you are a voluntary enrollee, and that means you have less than the 40 work quarters. And essentially what that means is that you have to pay Medicare premiums. And if you are a US citizen or a permanent legal resident, you may do that. The caveat here is if that you are under the age of 65, you cannot be a voluntary enrollee into Medicare. So then that was Part A premiums. Now we'll look at Part B premiums. The standard monthly premium for individuals whose income is $103,000 or less, and for a couple, $206,000 or less in 2024. The standard monthly premium is $174.70 a month. If you make more than that amount in income that you reported on your income taxes, you will be required to pay an IRMA. IRMA stands for Income Related Monthly Adjustment Amount. And a lot of people have a big change in their life. Either they have a disability or they go from working and making significant money, relatively speaking, to not working. And not making that income. So if you have experienced a major life-changing event, there's a one-page form that you should complete with Social Security to let them know that this change has happened. And that's important because, you know, we always have a delay in filing our tax returns. So when Medicare is calculating and Social Security are calculating this income-related monthly adjustment amount, they are looking at your income from 2 years ago. So you do want to make sure if you've had a change in that time period that you complete this very basic form to have Social Security make sure that you're not paying more in your premium than you should. Now we'll turn to the Medicare Advantage premiums. So premiums in 2024 range from, I'll give back, and I'll talk about that in a second, to several $100s a month, depending on which plan you choose. Remember that you always have to pay the Part B premiums, even if you are enrolled in a Medicare Advantage plan. That's the basis. Everyone pays Part B premiums if you're in Medicare. You have to continue to pay that Part B premium. If you only pay your Part C premium, you will be kicked off of Medicare. And some plans may subsidize the premium. They may say, okay, the Medicare Part B premium is $170 and change every month. The Medicare Advantage plan will contribute $25 toward that $170. That's what's known as a give back plan. Typically, when you're working with a give back plan, it means that there are not very many providers available in the network. So there's always trade-offs. You have to watch out for that. The Medicare premiums for Medicare Advantage plans, Medicare Part D, and the Medigap, the big tip here is to use the Medicare Plan Finder tool. There's a tool on medicare.gov that will provide you with very specific information about the plans that are available in your zip code, about Medicare Advantage plans, prescription drug plans, and Medigap plans, those supplement plans that Judy talked about. Be very careful to use only the official website. If you just Google Medicare Plan Finder tool, amazing number of really not helpful tools will appear from sometimes nefarious sites. So make sure that you go to the official website. And here's a link to that. But again, if you make sure that you're on medicare.gov, then you know you're in the right place. Other costs in Medicare, other than the premiums, are deductibles, coinsurance, and copayments, as Judy mentioned. And this is just a reference for you to let you know what those deductibles and copayments are. I won't dwell on this because it's just good resource information for you. And we're about to see some changes that will occur for 2025 that will be announced within the next couple of months. So how do you get assistance paying for Medicare cost sharing? The main program that I want to mention today is the Medicare Savings Program. These help lower income people to pay for all or some of the Medicare costs. And eligibility for the Medicare Savings Program is based on income, and in most states also on assets or resources. The Medicare Savings Program varies by every state, and these programs are administered in each state by the Medicaid agency for the state. However, you are not enrolled in Medicaid when you qualify for a Medicare Savings Program. This is a slide to just let you know how underutilized the Medicare savings programs are. Most people don't even know that they exist. And you can see, I won't go through all the acronyms, but that program that says QMB on the bar on the left-hand side is a program that pays for all the Medicare premiums as well as all the cost sharing. And you can see that 53% of people who are eligible for that program are enrolled in it, but the other 47 who are eligible are not enrolled. So there are a lot of, there's a lot of help out there, and you can find it through these Medicare savings programs. So how do you find the Medicare savings program? In the states that are using the federal guidelines, Medicare beneficiaries with monthly incomes that are less than $1,700 or $2,300 for a couple should be screened. There are many states that go as high as 246% of the federal guidelines. So please check out the chart here. There's a link, or look for on the computer the National Council on Aging. It's the best chart that I've ever found. They do a fabulous job with laying out the information for each state of how you qualify for the Medicare Savings Program. And if you would like a free Medicare Savings Program screening, takes about 15 minutes, you can contact your local state health insurance program. We partner with the SHIPs. They are the best thing ever in terms of being able to provide unbiased information to Medicare beneficiaries. They will help you to review qualifications for the Medicare Savings Program. And in addition, if there are other ways to help with cost sharing, such as the low income subsidy or other programs that are available in your area, the SHIPs, the local SHIP where you are, will be able to give you that information. And finally, I want to talk about eligibility, enrollment, and transitioning to Medicare in coordination with other Medicare insurance. Here's a link to a chart that I use all the time. Who do I contact, Social Security or Medicare? They partner in a lot of different ways, but they each have a piece of Medicare that is different based on what you're looking for. This particular chart has about 20 different questions, and then it has a checklist if you should contact Social Security first or Medicare first. It will save you a lot of time and anguish for looking up this particular chart and knowing where do you contact first. So that's my first big tip about eligibility and enrollment. There are 3 different ways to qualify for Medicare. Obviously, aging into the program, and remember, the Social Security full retirement age has gone up to 67, but Medicare remains at 65 or older, so you don't want to miss the boat if you're aging into Medicare. The other opportunity, one of the other opportunities, is through disability. If you're under the age of 65 but over 18, you have a 5-month waiting period to begin Social Security benefits, and then after you start receiving benefits, either through Social Security or railroad disability, then you have a 24-month waiting period. Note that if you are living with ALS, the waiting periods for both the beginning of Social Security benefits and the disability waiting period for Medicare are removed. So as soon as you qualify for Social Security, you will qualify for Medicare. Also, the third way to be eligible is if you have end-stage renal disease. Okay, so the initial enrollment into Medicare. So this is when the vast majority of people will begin Medicare when they turn age 65. And these are folks who essentially are aging into Medicare, but they are not covered by active employment insurance, which would allow you to delay enrollment into Medicare. So the initial enrollment period is essentially 7 months. and it starts 3 months before the month of your 65th birthday and continues for an additional 3 months. The first time that you can actually join or be eligible to receive Medicare is the month of your 65th birthday. Few things about transitioning from other insurance. Be careful if you are in the if you have Affordable Care Act insurance at this point, because you will want to sign up for Medicare as soon as you become eligible in that 7-month time period. You don't want to wait until the end of the plan year that you're in the Affordable Care Act and then join Medicare. It certainly would be cleaner for individuals, but it's not how the program works. So once you become eligible for Medicare, you want to make sure that you leave the Affordable Care Act plan and you join Medicare. Because once a Medicare Part A coverage begins, you lose the premium tax credits and any reduced cost sharing, and Medicare is required under the law to pay first. And then with regard to having multiple different types of insurance, which many people do, you have to be concerned with who pays first. It would be lovely if we each had a choice of who could pay first, but the rules are very prescribed. They are meant to be so that everybody knows what the order is, and you don't have an individual choice on what the orders are. So when you apply for Medicare and you're filling out that initial enrollment questionnaire, you're going to want to make sure that you provide all types of coverage. And this is really important because you want to make sure that whoever is billing knows all of the different types of coverage they should be billing for. And then they will know what order to bill the information in. And it's also important to know about this Benefits Coordination and Recovery Center. It's also known as the Coordination of Benefits Contractor for Medicare. And there's a telephone number there. And if you have multiple different types of insurance, whether that be retirement insurance, insurance through TRICARE for Life in the military or the VA, whatever that additional insurance might be, give a call to the Benefits Coordination and Recovery Center and make sure that they have received all of the information. It's just a really great insurance policy to make sure that the billing doesn't get messed up. If you have a personal injury or workers' compensation claim, Medicare will make a conditional payment conditioned on Medicare being paid back once a settlement is reached in a personal injury or workers' comp claim. And who pays first? So this is a chart that will give you a sense of which of the different payers are prescribed or required to pay, in which order they're required to pay. So if you have Medicare and Medicaid, Medicaid is always considered the payer of last resort. So they will be in, Medicaid will be in the secondary position. But there are squirrely rules around if you have a group health plan, meaning if you're 65 or over and there are 20 or more employees for the group plan that you are connected to that has active insurance, either through yourself or your spouse, then that group health plan would be the primary payer. However, if it's a small employer with less than 20 employees, then Medicare pays first. If you're disabled and you have Medicare because you're under the age of 65, the employer group is a different size. It's 100 or more than the group health plan would be in primary position. So again, if you're working with the Benefits Coordination and Recovery Center, that Coordination of Benefits Contractor, they will be able to tell you who is going to pay first and who would be responsible to make sure that that happens. And just a note about the group health coverage. If you are disabled, you're under the age of 65, the group health plan is more expansive. The group health plan could cover a family member and not just a spouse. There are a lot of these nuanced rules, and I'm happy to answer any questions as we go forward. But for right now, I'm going to turn the program back over to Judy.
Thank you, Kathy. That's such great information. And now I'm going to talk briefly about a big topic, which is choosing between traditional, often called original Medicare, and Medicare Advantage which is, as I said, the private insurance plans that cover Medicare services. So let's look at traditional Medicare first. And that's the next slide, please. And in the traditional Medicare program, the providers, healthcare facilities, and supplier networks are vast. Generally, you can see providers throughout the United States. Most hospitals and nursing homes and home health agencies participate in Medicare. Many physicians do throughout the United States and the United States territories. Generally, prior authorization is not required in traditional Medicare, so there's a fair amount of flexibility. And also security, because those providers that are available throughout the United States generally will be there for the entire year of that you choose traditional Medicare. And during that time, you won't need to get prior authorization to get a service covered usually. But there is cost sharing, as we talked about, premiums, deductibles, and copays. So financial considerations are important when, in order to afford being in and getting the service you need in traditional Medicare for that cost sharing. Medigap insurance, as Kathy just described, and other programs may be available to help. Medigap is insurance that covers the cost sharing, but it requires monthly premiums, and those can be high. It covers the cost sharing when Medicare has said it would cover. It doesn't cover additional services. And it depends on your state whether you'll be able to get Medigap insurance after your initial enrollment in Medicare. Only 4 states have very broad rules regarding that. There is no national right to a guarantee issue for people who have been in Medicare for after their initial Medicare enrollment period. And there's no national right for people who qualify for Medicare due to disability. That is very important. So people who are under 65 may not have a choice with regard to getting a Medigap policy to pay for the cost sharing. Also in traditional Medicare, you have to choose and enroll separately, not only in a Medigap plan for the cost sharing, but in Part D for prescription drugs. Now let's talk just generally about the Medicare Advantage program, which, as I said, is Part C. And this is a system, a web of private insurance plans. Now about half of Medicare beneficiaries are enrolled in these plans. And be sure you know that this is not in addition to or on top of somehow traditional Medicare. People call here often and think that they've gotten something on top of their Medicare, a traditional Medicare program, when they've chosen to enroll in Medicare Advantage, and have later in the year found out that one of their providers or healthcare choices is not in the network of the Medicare Advantage plan. Most Medicare Advantage plans cover Part D, the prescription drug coverage, and they must cover all the services, at least, that are in Medicare Parts A and B. One of the major drawbacks of the Medicare Advantage plan is that they have limited networks of providers. If you travel a lot, if you have family you might want to stay with, if you're ill or injured, make sure you check to see that the facilities you would want to use are ones you would be able to if you moved outside your geographic area. Also, most plans require prior authorization for at least some, if not most, services. That's also not true in traditional Medicare. Medicare Advantage plans, as I said, are legally required to provide at least as much coverage as traditional Medicare. And they also may offer oral health, some vision, and increasingly some gift cards. They call them flex cards. Make sure this is all of these will be of practical value to you, if you're enrolled in a Medicare Advantage plan, because those networks of providers may be limited. You may well need prior authorization. And unlike in traditional Medicare, providers in Medicare Advantage plans can terminate their participation in the plans during the contract year. And that doesn't necessarily mean you can get out of the Medicare Advantage plan. That does happen. Now, let's go ahead, Kathy, to a couple more slides. There are towards the end of this section, please. Next one. There are financial considerations. What can you afford? Can you choose to be in traditional Medicare and meet those cost sharing requirements as we described? Also, there may not be a choice because in most states, you'll be impacted by pre-existing conditions and may have to wait or be limited in ability to get a Medigap plan. And if you're under 65 and qualify due to disability, you may not be able to get into one of those, to purchase one of those plans. And if you can you afford the premiums? Can you afford to go without that cost sharing help? Kathy described some of these, that there is help for cost sharing to pay the Medicare cost sharing due to low income. And it doesn't require you to be as low as Medicaid income does. So the Medicare savings programs and also in Part D prescription drug coverage, there is a low income subsidy. So those are things you'll want to look into. Do you also, as she mentioned, if you qualify for other insurance, be it Medicaid or employer or military coverage, you may not need a Medigap plan and may be able to manage in a Medicare Advantage plan. Next slide, please. This is a slide from our friends at the Kaiser Family Foundation, KFF, that tells us about some of the potential advantages and disadvantages that are trade-offs for beneficiaries. And I encourage you to look at these carefully when deciding on your own behalf or someone you're helping, whether you should and can get into a Medicare Advantage plan, or whether if you can afford it, you should stay or get into traditional Medicare. And be aware that not everyone, as I've mentioned, has choice. And increasingly, about 1 in 5 beneficiaries is retired from a company, public or private, that actually has a Medicare Advantage plans. And so there isn't always choice. But the question will be limited provider networks versus open providers across the country in traditional Medicare, possibility of having prior authorization requirements in Medicare Advantage versus unlikely to have that in Medicare, traditional Medicare. And then, of course, the traditional financial concerns I mentioned, and the ease of enrolling in Medicare Advantage to start with. But make sure it's something that you want, because you may not, over the long term, you may be in one of the many majority of states where you can't really make a choice after it's already been made. And now I'm happy to say that we're able to go to questions and a little bit of discussion. Thank you very much.
All right, so we'll pull Kathy back up and we'll pull Patrick up. And I'm going to start, we've had several questions about the Medigap issues that you guys have brought up. One from Connecticut specifically that says, hey, what problems am I going to have if I want to go to traditional Medicare from the MA plan I've been in for the last 4 years? One not from Connecticut, if an MA plan is chosen, why is there a limited ability to switch back to traditional Medicare with a Medigap? And then another one, what are the 4 states where you have the option? And then we had a couple people asking, wait, do MA plans act like a Medigap plan? And do Medicare savings programs pay for Medigap premiums? Can you have Medigap and an MSP? So Medigap is a big question issue.
Yeah, we saw that from the prior registration questions too. Kathy, maybe we can team this.
Sure.
Yeah, okay, you want to start? Oh, okay, I'll start.
Okay.
Let's see. So we're headquartered, our flagship office is in Connecticut. Happy to say our representation has helped broaden coverage for people in Medigap in Connecticut. It's something that could be parroted. We encourage others to do so in other states. In Connecticut, due to an informed legislature, we have legislation that requires people under 60, plans that want to offer Medigap in Connecticut must offer at least one policy to people under age 65 who qualify for Medicare due to disability. Also, they must all, to do business in Connecticut, guarantee issue. And so you can switch back and forth between traditional Medicare and Medicare Advantage during certain periods of time You're not limited by the fact that you wouldn't be able to get a Medigap plan. The other four states that have some variations on these expanded rights are Connecticut, Massachusetts, New York, and Wisconsin. Is that, or Maine?
Maine.
Maine, yes. Thank you. So that is, in order to do business in state, a state legislature can expand the federal rights of the Medigap plan. Medicare savings programs do not cover Medigap costs, and in fact, if you qualify for Medicare savings programs, you, especially the QIMBY, Qualified Medicare Beneficiary Program, your cost sharing would be all or some of it would be covered, and you wouldn't need a Medigap plan, and it shouldn't be something you pay for. Kathy, what am I gotten wrong or missed you want to add?
Yeah, I think the big thing is if you're at all interested in this topic and you're having difficulty because you can't get a Medigap plan in the states that you live because it's too expensive, or you don't have guarantee issue after the first 6 months of being on Medicare, contact Congressman Lloyd Doggett. He is the individual who is has a bill called filling the gaps, Medigap. Anyway, it's a fabulous bill that has been introduced, and we really should all get right behind it. It is a game changer and would really be a fabulous federal right for everyone to have the ability to get in and out of a traditional Medicare or Medicare Advantage plan as they need to, and make it much more affordable.
And you don't need Medigap and shouldn't be offered or paid for one if you're in a Medicare Advantage plan. And it is an opportunity for state-specific advocacy as well.
Right, and if anybody wants, we have a package at the Center for Medicare Advocacy that includes the Connecticut statute. It really, Connecticut, as Judy mentioned, is a model of the way that states should have Medigap rights. And so until such time as we can get a federal law on it, people are working at it very hard on at the state level. So again, happy to share that information.
And this is something we might be able to work with I AM ALS about, because I know from conversations that there are federal legislators. Kathy mentioned one, also Senator Wyden has expressed some surprise, who's the head of the Finance Committee in the Senate, that there are still pre-existing condition limitations and the inability to get coverage for people who qualify for Medicare due to disability in most states besides Maine, Massachusetts, Connecticut, and New York. Thank you.
Right. And just to give you an example,
covers most of it.
I'm sorry, I'm going on. Just to give you a quick example, in Connecticut, if you had ALS and you got a Medigap plan, it would cost you less than $300 a month to have all of the cost sharing that's covered under Medicare, except with a few very minor exceptions. So a big difference in affordability than most states.
All righty, thank you for that. Now, I think we might want to pull Patrick in for this one. This is sort of an eternal question. Sherry gave sort of a personal example, but it's a general problem. Her husband's a 39-year-old ALS patient. There are a few agencies that service their area, home health agencies, and they certainly take Medicaid and self-pay, but how can they get Medicare to cover their in-home health care?
Yeah, thanks so much. And I think that's a great question and something that certainly a lot of the folks that we work with do experience. I would say in terms of the support that we provide, we usually work with folks on a case-by-case basis. I would say that there's so many factors, specifically including location, that can really impact the type of care that's available, the coverage, the cost, and that is from a private perspective and also through a public perspective. So I think in those kinds of circumstances, we try to get as much information as we can, and then utilize that information to either refer out to another organization to see what might be available through their services, or to kind of work concurrently to try to either stack different service providers, determine if there is a public or private grant option perhaps, but certainly working with organizations like the Center for Medicare Advocacy or local kind of state-based aging and disability service providers to see what makes the most sense for that particular individual, specifically in terms of their location and what those service options are.
And from a Medicare perspective, I would ask any provider if they bill for outlier charges. Those are charges that Medicare allows for higher resource need individuals, and those payments can be up to 5 times what Medicare standardly pays for home health care.
And remember, we have resources provided briefly in this session, but great numbers of them on our website about what Medicare legally should be providing coverage for. It's one of our priority areas.
All righty, thank you all for that. Boy, the questions keep flying in. Apologies for my hesitation here as I'm scrolling through the new ones that are popping in. Somebody noted that one of the slides, when we were talking about creditable coverage, someone had a question about COBRA. I know for a fact Kathy can answer this one. When is or isn't COBRA creditable?
Yeah, only in Medicare Part D. So if you carry over a prescription drug plan, then you don't have to worry about penalties as long as you have prescription drug through a COBRA plan. COBRA is a continuation of employer insurance. And remember what I said about employer insurance. If you have insurance through an active, either if you're under 65, an active family member or yourself, if you're 65 or over, if your spouse or you are covered under active, meaning someone who carries the insurance is actively employed, then then you can delay Medicare. If you receive COBRA, that continuation after employment ends, then it's not based on active insurance, active employment anymore. So the insurance for Medicare Part A and B, typically Part B, because most people, as I mentioned, get Medicare Part A premium free. For Medicare Part B purposes, it's not considered to be the place of Medicare. And Medicare, more difficult, it doesn't pay primary once you are no longer actively employed. And then you can't get into Medicare until the general enrollment period, which begins in January of the following year. So there's all kinds of pitfalls. So my general advice to everybody is don't take COBRA if you are Medicare eligible. Even if you're not enrolled, don't take COBRA unless it's just for Medicare Part D. Now, if you're under 65 or you're not yet Medicare eligible, COBRA's great. But it's the folks that become Medicare eligible. You want to jump into Medicare as soon as you can.
All right, thank you. A point of note brought up by Michelle, who's one of those good guy agents that frequent our webinars on occasion. She just wanted to make sure that in all this talk of private plans, and particularly Part D, that beneficiaries have to shop every year. Don't stick with what worked for you last year.
Good
I
point,
think all
Michelle.
of our advocates will agree.
Absolutely. Same with Part D, your prescription drug coverage will change from the plan from year to year. Same with Medicare Advantage plan. And that's one of the good things about traditional Medicare is it is what it is. It could be better, but at least it won't change from year to year. Well, that's not true, but you don't have to rethink who the providers are in it.
Yeah. We had a couple questions on prior authorization. You brought that up as a significant issue potentially in MA plans. Can you expand on why prior authorization is an issue? What are the issues in getting prior authorization, asks Martha.
It may be denied. It may take time. It may therefore delay when you get the care that your doctor or healthcare provider has ordered and thinks is necessary, and might require appeal of that, seeing if you can get just the doctor or provider to help with an appeal of the prior authorization denial. Should it be denied? There's a lot of concerns about inappropriate denials of getting a service because of prior authorization, and also the delays in getting the service and waiting for a prior authorization to come through.
All right, I think that covers that. Excuse me. I know we are a little bit over time here. You guys want to maybe take one more? Are we okay with that?
Sure.
All right. You mentioned that there's no cap under traditional Medicare for therapy services. It's sort of important to our target audience
Yes.
here today. What about Medicare Advantage? Can they impose a cap?
That's interesting. In fact, and I don't believe they can. I think that the limitation on how much therapy is provided is at least theoretically the same in Medicare Advantage as in traditional Medicare. In both instances, people may be told that they've reached their limit. It can be a billing problem or a financial consideration for the provider. But make sure that you consider these slides and information we've provided and make sure that you know that there is no necessary hard cap to being able to get those services. Does the doctor and therapist still think the care is necessary? Would you decline without it? You shouldn't be required to show that by having it pulled out, decline, and go back in. So no cap legally under the law.
Yeah. And after about $2,700 of services, there's a billing modifier that has to go on the claim so that you can go over that level. And then if you get somewhere into the $3,000 level of services, the government has the right to review the claims, but it's very nebulous. And all of that, the billing modifier and the right to review, go away in 2028. At that point, there is no cap at all, or no, I shouldn't say no cap. Because there's no cap now, but there's no extra steps that you have to take. Those were just put into place kind of temporarily, but there's no cap, as Judy said.
All right, thank you. I want to note for everybody today, because we've had several questions, yes, indeed, we are recording the presentation and we will get a link out to everybody who registered today. We'll also resend slide links and we'll ask you to do a little survey on what you thought of us today. I would love to ask Patrick if he has any closing words from I AM ALS before we end today.
Thanks so much. Yeah, I would just say if anyone is looking for assistance or would like some one-on-one support, I certainly welcome you to reach out to us. You can connect directly via email if you'd like. It's gethelp@iamals.org, and we'd be more than happy to assist and support as needed.
Fantastic. Thank you very much. I appreciate everybody's attention today, and thank you to the hundreds who stayed on a little bit late today. Really excellent, fantastic questions, great input on the registration. Thank you all so much. Thank you very much to Aditi and Patrick, especially for joining us today. Be on the lookout for future presentations. As Judy mentioned, we have one coming up in September on Medicare Part D. Always confusing, always a good thing to have some information on. And with that, I will now conclude today's presentation. Thank you all once again.
Thank you very much. Thank you, Patrick.